We're going to need to go ahead and get started. I know we still have people that are going to be coming in, but we have a lot of things yet to come, and want to make sure that we can get to all of them. Okay, now this particular session, evidence-based practice about COVID behaviors prior to COVID and then after, is the brainchild of this one here, Christopher Hudgins. Now, I got pulled into it for some reason. I'm not sure why, but we developed a research project and we've had some up and downs on it. We have some preliminary results that Christopher and Doreen are going to tell you about today. And I have stories for both of them too. I don't know. We'll go with the bio. Doreen Wagner is one of our PhD nurses, and so when we go to talk to the people at the Capitol, we always like to introduce her as Dr. Wagner, because that carries some weight in the minds of our legislators, but it does in ours too, because we need nurses who are doing research. She is, you heard her say, a professor of nursing at Wellstar School of Nursing. She has students here today, so we're growing and replacing her own. Christopher Hudgins is a clinical manager of 3M, and he's worked in the operating room for over 27 years. Now, Christopher is one of our, I don't know if you've ever seen the videos that I put on Facebook, but whenever we do something at the Capitol or meet with the legislators, we've developed a format for smoke busters, and we do the smoke buster video of what we had done at the Capitol. Christopher is one of the original smoke busters, along with Pat Thornton and Doreen and Vanjie and many others. And so that's what we've been doing with Christopher since 2019. He's also on the National Nominating Committee and is the chair. You didn't tell me if it was all right to say that.
It's okay.
It's okay. He'll be the chair of the nominating committee. Next year. So yes, once again, when I tell you we are rich with nursing leaders in Georgia, that is absolutely the truth. Now, I've mentioned several times today how fortunate we are to have our vendor sponsors, and they sponsored many of the lectures that you will hear today. We have signage all around, and we've offered them the opportunity to come up and say a few words to you, so you will see their faces too. It's important to be able to put a name with a face, and it helps you establish and advance that relationship. So we have Liam Burns with us today from ConMed. You want to come up and say a few words, Liam? We figured I didn't think I had ever met him, and when I met him last night, I said, I know you, and it was from years ago from another place. So please.
Thank you very much. We are very excited to sponsor this lecture in particular because ConMed is on a mission to help you make the OR smoke-free. And this is a personal mission. We know that evidence is what drives surgeons' behaviors. What we really want to see is that they're empowered by the people here that are in the OR with them, that enable them to do great things. They can't do it without all of you. And when I hear the years that Brenda and Vanjie and all of you have been on this smoke mission, it's really exciting to see the success that we've had more recently. ConMed has accepted this mission as well, and I'll tell you why it's personal to me. So when I was growing up, both my parents smoked, about a pack and a half, 2 a day. I'm one of 8 kids from an Irish Catholic family. You did what you were told. You sat at the breakfast table. You ingested that smoke every single day. And as a kid, guess what? I didn't have a choice. That's where I lived. My parents made that decision for me. And I think back on that now. I'm a marathon runner. I pray that there hasn't been any serious damage done. But I didn't have a choice in that because I was just a kid in that house. I think that when you go to work every day, you should have a choice that you go to a place that's safe to work. And that's the responsibility of the surgeons, the policy leaders, the OR directors, and everyone. And so I know it's difficult to advocate for those needs, but I think it's something that we shouldn't have to fight so hard for. And so ConMed is on this mission with you to make every OR smoke-free in the world, and we're going to do everything we can to support you. And I think this evidence that you'll hear next is one of those other bricks of this wall that we're building to help make the OR a safer place for you to go to work. So we thank you for all the work that you do every day. We're proud to be part of that in every OR in the world, and we'll continue to support you as best we can. Thank you.
So Christopher, come on up and tell us what you learned.
All right, can you hear me? Perfect. Well, first, I also want to thank ConMed for sponsoring this section. We really appreciate it. We appreciate everything that you do for us. And I also want to thank Brenda. She was a little bit, can we turn that a little bit? I also want to thank Brenda because she was a little bit humble. She did a lot of work on this project. We actually started over a year ago, and we applied for a grant through AORN. If you don't know, AORN grants research, gives research grants each year to help nurses do research out in the field and in the, your hospital. So we applied for that. Unfortunately, we didn't get it, but I really encourage everyone, if you're interested in research, if you're interested in doing a project, to apply for that because there is money available for that. And I also want to acknowledge the entire research team. So myself, Brenda, Doreen, and Sharon, who works at Kennesaw. So this is our disclosures. Me and Doreen have no conflict of interest today. And for our learning objectives, we're going to talk about the nurse's knowledge of surgical smoke hazards, national recommendations for evacuation, and we're also going to talk about the differences in smoke evacuation before and after the onset of COVID-19 in the US, and we're also going to talk about those results as they apply to us here in Georgia. So just some quick background. So surgical smoke is present wherever there's surgical procedures. And we've known this, that surgical smoke contains bacteria, viruses, blood, and tissue particles since about the 1980s when research started being done. And Vanjie mentioned this earlier that there's approximately 500,000 nurses or healthcare workers that are exposed to surgical smoke every year. So how this got started, about a little over a year ago, I think it was in March or April, we were working at the Capitol presenting evidence through a study committee to the legislators trying to get surgical smoke evacuation legislation passed. And one day Brenda called me and she said, have you heard about the new recommendations that some professional organizations are making concerning smoke evacuation for COVID, during COVID? And I had not. And you know, we knew at the time that there was zero research that linked or showed that COVID-19 was in surgical smoke. So I was really surprised because here we have these professional organizations that are now making recommendations based off of no research. And what was really interesting is one of those organizations had actually testified against surgical smoke evacuation on the Capitol at the study committee. So I was really upset because they were making these recommendations based off of no evidence, yet we have had evidence for years that showed that viruses were actually in surgical smoke and could be passed along to healthcare workers. So I started thinking about that and what we could do. And so I thought it would be good if we could collect some data on the surgical smoke evacuation practices in ORs, both before COVID hit and then after COVID hit. And I thought that maybe if it showed that there was no difference in smoke evacuation practices both before and after COVID hit, that we would have some evidence that we could take to our lawmakers to say, listen, we know that recommendations don't work. Here's the evidence that recommendations don't work. And this is why we need you to pass laws to help protect us, because the recommendations aren't working. And so that's kind of what kicked this all off. And we decided to do a study about it. And those professional organizations that made those recommendations, the first one came out in March, on March the 30th of 2020, and that was from SAGES, which is the Society of American Gastrointestinal and Endoscopic Surgeons. And the other one was the American College of Surgeons on April the 1st, just a day later. And both of them basically recommended that if you were doing surgery, that you should use smoke evacuation. So the purpose of our study was to examine perioperative registered nurses' knowledge of electrosurgical smoke and determine practices of surgical smoke evacuation in the operating rooms both before and after COVID hit. So this is a descriptive study, and we used a survey model. So real quickly, I'm going to go through the literature review. Vanjie covered most of this when she talked, but we've known about the hazards of surgical smoke since 1975. So we've known about it for about 46 years. And in 1980 is when there started to be studies about the contents of surgical smoke. And in 1981, a study came out that showed that surgical smoke contains the same contaminants and harmful substances as cigarettes. And Vanjie, I think, says it best, and she said this on one of the news segments that we recorded here in Georgia, when she talks about when you smoke a cigarette, you are inhaling filtered tobacco. But when you're in the operating room and you're inhaling surgical smoke, you're inhaling pieces of human tissue. And we've known about that since the 1980s, and here we are today still fighting the fight. Another study showed that there's 150 chemicals that are found in surgical smoke, and that some of those are volatile organic compounds, which are basically just organic chemicals that have a high vapor pressure at room temperature. It means they're very volatile, and they're responsible for the odors and the scents and the perfumes, as well as pollutants. And then another study looked at polycyclic aromatic hydrocarbons, or PAHs, and those are pollutants that are generated primarily during incomplete combustion of organic material. And what this study found was that during mastectomies, they looked at 10 different mastectomies, and the estimate for cancer risk for surgical staff was 20 to 30 times higher than outdoor. Also, the anesthesia and the surgeon and the anesthesia were at risk for cancer. And anesthesia was more at risk because they work long hours and they work multiple cases. Where our surgeons are in the room for one case a day, maybe two cases a day, twice a week, the anesthesiologist or anesthesia provider is there for multiple days. Just like us, we're there 8 hours a day, 12 hours a day. And then we've had recommendations for surgical smoke evacuation since 2004. And then in 2017, AORN produced the guideline for surgical smoke. So that's been around for quite some time. And again, here we are still talking about the need for smoke evacuation. So for our study, here's the methods. I'm not going to go through every one of them. What I will say is that, so our survey was delivered to 21,311 members of AORN. Of those 21,000, 3,616 opened the email. Of those, 240 actually clicked on the survey. And of those, 129 completed some or all of the survey, but only 100 completed all of the survey. So I mentioned that because it's really important. I know we get a lot of emails. A lot of people are burnt out from conference calls and emails, and that's why we're so glad to be here together today. But if you see a survey come through from AORN, it's really important, if it's applicable to you, please take it, because this is a really low response rate. If we would have had higher response rate, it could have had more impact. So, take a chance. So take some time to look at your email, look at the survey, see if it's applicable to you and if you can take it, because it could have been really more impactful here if more people had taken the survey. So the results from our survey, the characteristics. So we had responses from people in 31 different states. 31 people from Georgia took the survey, and something that's important to note as we go through the results of the rest of the survey is that, so not all the numbers are going to add up to 100%, because some people didn't answer every question. So we included results from everybody that took some or all of the survey. So not everything's going to add up to 100%. And then you'll see post-COVID throughout the survey. And that just means 2 weeks prior to when the person answered the question. So for our participant experience, we had people who had worked with electrosurgical units. The range was between 0 and 40 years, a really wide range there. And most of the people that took the survey were circulating nurses, followed by nurse managers. And then this is one of our first questions regarding the actual use of surgical smoke evacuation products, as well as surgical smoke exposure. So you'll notice that Georgia there is at 83% of nurses said that yes, they had some surgical smoke exposure training. And then you'll look at the response for the product training. For Georgia, 53.3% of nurses in Georgia that took the survey said that they had received product training. Also note there that 40% said no, they had not had product training on smoke evacuation products, and 6.7% were unsure. So 46.7% either had not or were unsure if they had training on products that they use every day, because we know that surgical smoke is produced on every case. The next question was about their recommendations after the onset of COVID-19. So how many people were made aware that there were some new recommendations? 60.9% of people overall said that they were not aware that there were new recommendations from the American College of Surgeons and SAGES. And 57% were made aware not from their facility, not from their educator or their manager, but from AORN. The next question is about the knowledge of surgical smoke. So we included some knowledge-based questions here. And the first question was, harmful elements and substances known to be contained in surgical smoke include. And the correct answer was bacteria, carcinogenic particles, hydrocarbons, hydrogen cyanide, and viruses. And 58.4% of the respondents got that correct. The next one was on the potential dangers of surgical smoke for the patient. And 21% of people got that correct that responded. And the answer is there: carbon monoxide exposure, delays caused by decreased visibility of the surgical field, and port site metastases. And the next question was, surgical smoke generated during laser procedures is blank surgical smoke, smoke generated during electrosurgical procedures. So just out of curiosity, how many people think that it's more hazardous? If I raise a hand. How many people think that it's less hazardous? And how many people think it's equally? So that kind of matches what close to what our respondent said. So 3% got that correct. So surgical smoke generated during laser procedures is less hazardous than smoke generated during electrosurgical procedures with lasers. The reason for that, just as an FYI, is because the size of the particles makes a difference. So during laser procedures, the size of the particle is about 0.5 microns. And during electrosurgery, the size of the particles is about 0.07 microns. So the smaller the particle, the deeper in the lungs that the particles can get. And the next question was, the decision to use a smoke evacuator should be based on, we'll just take a quick poll here as well. So how many people think that it's surgeon's preference? How many people think that it's a patient's request? A group decision between the surgical team, everybody talks about it. And then whether the procedure will generate smoke or not. Yep, that's the correct answer. 79.2% of respondents got that correct. So in the AORN guidelines, it actually states that smoke evacuation should occur on all surgical procedures. And in that same recommendation or guideline, it says that no one particular practitioner should make the decision on whether surgical smoke evacuators are used or not. So good job. Most people got that one right. And so we have a polling question. And so just a polling question for the audience. So how many people have actually read the guideline for AORN's guideline for smoke evacuation? Good amount of people. I'll be honest with you. I read the entire guideline when I was sitting before I sat for my CNOR, and I hadn't read it much since then. I read bits and pieces. But so when we started on this journey, I sat down and read it again, and it's an easy read. There's a lot of great information in there. So I recommend everybody take a look at it. For our study, this was actually one of our study questions, and 64.4% of people overall said that they had read it. 27.7% of respondents said that they did not read it, had not read it, and 7.9% of people were unsure. All right, so now I'm going to let Doreen come up, and she's going to talk about the rest of the results from our survey. Doreen?
Wow. He did turn his off. I think I'm just missed feedback. Okay, I think it's working now. All right. It's nice to see everybody. Thank you. One of the things I wanted to point out about this study, I think we need to turn the volume down for me. I have a big mouth. I think that, no, yeah, thank you. we had tested this before, but apparently the feedback just wants to jump in there. I just wanted to add a little bit to the introduction that Brenda gave, just that I've been a perioperative nurse for 36 years. And for the last 20 years, I have been in academia, but I have always maintained a perioperative connection through my research and through sharing with students, and then finally getting to have, after I broke down some barriers, having students in the operating room and sharing this information about surgical smoke with them. It's quite interesting that they're like, oh my God, they're appalled. Why would I want to work in a place that is not protecting me against known hazards? So thank you, Brenda. So that is something that we need to make sure that we keep working. And we do have 2 bills, one in the House and one in the Senate. So we are going to get it done this year. That is something important to us. I'm also the chair-elect for the council, so I'm looking forward to seeing more than this group of people next year when we have our next state meeting. So I appreciate everybody's attendance today for sure. I've been involved for, gosh, 33 of my 36 years in the AORN, from the chapter level up through national. And being on the research committee, I wasn't able to even look at the study that came through because I knew about it, but I was not in on the study until after I finished my chairmanship as the research committee at AORN, and was really happy to be able to get involved. So let's dig a little bit more into some of the data. And I will tell you, we were not able to have sophisticated statistics because we didn't meet the number that gave us power with our statistics. We only had 2 sets of information that we were able to have any kind of statistical significance. So this is definitely preliminary data. Brenda and I and Christopher and Sharon, who's the statistician on this project, have been talking about trying to see if we can send out to the rest of our membership at AORN, see if we get a little bit more, but we're also going to talk to our surgical tech partners and see if we can send out surveys to them. They're part of our team and can give us some good information too. So we'll adjust this survey and include them, and hopefully we'll have a good piece of literature that can get published. Right now it's not publishable, and so that's really sad. This is good evidence and it gives us that knowledge we need. So if you see that survey, like Christopher said, please take one. So when we're looking at Georgia's response, and we didn't do Georgia's response on all of these, but I wanted to point out a few. Before the onset of COVID-19, did the facility have a smoke evacuation policy? And what's interesting is that we had a good number of people that don't in Georgia have a policy. I was very surprised by that, actually. And other states around the United States, a little bit more percentage rate there. And then the following below there, the response to COVID-19, did your facility update or change your smoke evacuation policy based on COVID? Georgia, we had a few more people say yes, that occurred, but we still had a large percentage that didn't make any changes or develop a smoke evacuation policy. So how well is the smoke policy being followed? And when we say post-COVID, the questions on the survey were basically saying during the last week. And this was post-COVID when we sent this out. And before COVID, we had the before and after questions throughout. So what we're looking at is before COVID, policies being followed almost always and often, not too bad. So beforehand, about 52%. And then after COVID, we're looking at about 67% if they had a policy, they were following it. And then we're looking at how often did you use a respirator mask? Now this would be an N95 or PAPR along the half face piece with purifying respirators. So how often did you use a respirator mask during surgical procedures using ESU? So before COVID, basically nothing. After COVID, a bit more, about 21% always or frequently. And this was, if you'll see, we have the chi-square formula down at the bottom where we did have statistical significance with this. Doesn't look like it when you think percentages, but when you look at the statistics of it, where you're showing whether or not there's a relationship between two variables, we did see that there was a change. And then there's also looking at the use of the respirator mask. We had a difference in seldom and never, that they hardly ever used or never used a mask, a respirator mask. During COVID, you see that that number did change a little bit, about 55%. How often did you use a respirator mask that's fit tested? This is something that was quite interesting, and another statistically significant data set here. So when we're looking at this, we're seeing the statistically significant piece of this is that basically people aren't wearing fit tested masks, which is unfortunate. So how many people in here, hopefully most people in here, use smoke evacuation devices on every case? Yeah, a few hands. Well, what percentage of cases used smoke evacuation before COVID and after COVID? So before COVID, we're looking at between 51 and 99%, only 31% before COVID. Interestingly, people are saying that only 27% are doing it after COVID. I don't have an explanation for that. And never using it after COVID came about increased from the before. So interesting data, and would like to dig into it more and get more people involved in responding so we might get a better picture of this. This is just a snapshot. When we have smoke evacuation devices, when they're not used during the surgical procedure, who is usually making that decision? During COVID, we see it's decreased a little bit from before COVID, where it's become a little bit more of a team effort, but it is usually the surgeon is making that decision. What about exposure monitoring? Does anybody in here have exposure monitoring for worker exposure to surgical smoke? It is very, very few, little to none people said yes to this. So we have 98.9% that received no smoke exposure monitoring. That's something to think about. So when we look at all of this data, and again, it is just a snapshot, and we only had a couple of statistically significant points. However, we're looking at 77% of our nurses that were surveyed received education on what is surgical smoke, and 96% of them understand that the surgical mask does not provide sufficient respiratory protection during any aerosol producing or ESU procedures, and we use them 99% of the time. So wearing a surgical mask protects the patient, as Vanjie said. It does not protect you. You need to wear a respirator if there's no smoke evacuation to get some protection. Smoke evacuation protects you. 58% of the nurses surveyed no general types of harmful substances are found in surgical smoke. And they also understand that potential dangers of surgical smoke to patients are understood. Only 21% of people that were surveyed understood that patients also have danger related to surgical smoke. So we have really less nurses that's received the education about the surgical smoke evacuation products too, which was interesting and makes you wonder about some legal liability, not knowing what kind of products you're using. So we've got nurses that appear to understand that there's harm in surgical smoke. A surgical smoke evacuator should be used. And we also have information that should be in policies. They understand what things should be in policies. And our policies are not found at many of our facilities. So we understand things, but we're not putting them in our facilities and sharing it with others that don't maybe have that same knowledge. And when we're looking at no statistical significance in this standpoint of difference between surgical smoke policies before and post-COVID, it's rather sad. There were some statistically significant findings that we went through. So more nurses use a respirator mask post-COVID versus before COVID. However, fit tested respirator masks are not routinely used either before or post-COVID. And up to 52% of our nurses that were surveyed report the surgeon is the decision maker related to the use of smoke evacuation during procedures before and after COVID. We're a team, not one person should make this decision. And then surprisingly, the percentage of cases that use smoke evacuation have declined since COVID occurred based on the opinion of the nurses surveyed. And even with knowledge of the harms from surgical smoke, precaution practices really are lacking. And exposure monitoring, have we even heard about it in our facilities? Very, very little. Nurses are being exposed and we don't know how much. Limitations, we've already mentioned the limitations of our study. We did not have enough survey response for finding any power behind our statistics. So it's not generalizable. It is a snapshot, and we are going to work on getting more data so we can publish this. I think it's important. There are nursing implications. Let's look at management's implications first. These are rather broad. We could get really detailed. We need to ensure, management needs to ensure that standard operating procedures and policies for evacuation are available for staff, and need to also work on guaranteeing that smoke evacuation devices are available for all smoke generating procedures, which are basically all our cases. The use of exposure monitoring, doing air sampling, it's not hard to do to assess surgical team exposure to surgical smoke is something that we all need to advocate for as well. And then making sure that our PPE, especially our respirators, are fit tested before we use them to make sure that we are getting the benefit of those masks. In education, using our AORN guidelines as that Bible to help us with our education, to increase the knowledge base of our staff about the hazards of surgical smoke and why it's important to use smoke evacuation devices. Helping with onboarding and competency verifications, making sure you're adding that information about products too. Continuing our partnership with our vendors to bring them in and help us talk about products. Develop and promote, use that policy on our practices with surgical smoke evacuation. And then making sure that we discuss any updates that come out related to legislative activity, related to regulation. And then practice, join your advocacy groups. You're here today, join Georgia Council, be involved, go clear with AORN, try to get that going in your facilities. Collaborate with the development of the smoke policies to make sure your facility has a policy. And when you're using smoke evacuation devices, make sure you're doing it for all of your cases that are generating smoke. And we are going to have some legislators come today, so making sure you talk with your legislator about why this is important to regulate these toxins coming into our air. Our polluted air in the operating room needs to stop. And in research, We need more than just surveys. We need really large design studies that are also not just in the laboratories where they burn tissue and measure that. We need to have real clinical studies. And epidemiology, we have to look at longer longitudinal types of studies as well to assess that cumulative impact. We have, case studies that are brought forward and people sharing their stories, but there's not those long studies that look at the harm that's being caused to us. And just to conclude, OR nurses are exposed to surgical smoke routinely, and we know that surgical smoke contains particulate matter, contains blood, chemicals, viruses, and bacteria. We have insufficient steps that are being taken to protect us in the operating room. We're also not protecting our patients. We need to really work hard on that knowledge level to help everybody understand that harm is happening and we can stop it. And there's our references. And I don't think we have any time for questions, but you can catch me later.